Welcome to Neuro Connections, a vodcast series developed by the World Stroke Organization and Ipsen. The series aims to shine a light on the experiences of people post-stroke and discuss what's involved in providing consistent, high-quality care to meet their needs. Hi, I'm Dr. Michelle Nelson, and in this three-part series, we'll hear from stroke experts from around the world as we discuss post-stroke care and the rehabilitation landscape. We'll look at solutions to improve patient care, support recovery, and reduce healthcare costs. Stay tuned for some fascinating insights. Welcome to episode 2 of Neuro Connections. I'm your host, Dr. Michelle Nelson. In the first of our three-part series, we talked about the state of post-stroke care and rehabilitation globally and identified some opportunities for improvement. In episode 2, we're going to talk about what good or even great post-stroke care can look like for people in the long term and what will it take to achieve it at both the care delivery level and at a systems level. We're joined today by two expert colleagues, Dr. Janet Bettger, Professor and Inaugural Vice Chair for Research for the University of North Carolina Department of Physical Medicine and Rehabilitation, and Stacie Broek, a stroke survivor living in Switzerland, who's a patient advocate, published author, and motivational speaker. I have been looking forward to this conversation for quite a while, so let's jump into it. Stacie, do you mind if I start with you? I think it would be really important and really interesting for our listeners to hear some about your experience. Maybe you can share some of your experience of your stroke, but particularly through rehab. And if you wouldn't mind, that feels like a great place to kick off.
Absolutely. Thank you. So I had my stroke in Japan 5 years ago. And I really couldn't see myself getting better with this more traditional rehab setting. After I woke up from a 10-hour surgery, I couldn't walk, talk, or feed myself. Standard rehabilitation facilities didn't meet my needs or my expectations. I didn't want a cookie-cutter approach. The usual exercises felt ineffective. They just felt arbitrary, and they didn't really help me regain function in a meaningful way. There were people that I thought were on Team Stacie, but they ended up not supporting my goals. I think these false starts were disheartening and really underscored how crucial it was to find the right people. Anything that I could focus on my goals, my passions, that was what got me through the day.
It's really interesting how you talked about how maybe misaligned, is that maybe the wrong word, Stacie? That your goals were, how your goals were with what the plan of care was. It's something that we probably need to amplify globally. Like, it doesn't matter where we are. It's asking people who've experienced a stroke and their family members, what are their passions? What are they interested? How do we best direct rehab and the whole recovery process to what people want to be doing? And have that really drive the plan of care.
Yeah, it's interesting, isn't it, how we talk about goal-oriented practice and goal-oriented rehab. And Stacie, I know interacting with you has certainly created a bit of a critical conversation about whose goals, in what time, again, how do we actually move rehab and recovery services to support. Janet, I know you're a rehab clinician first, researcher and professor. So how does that show up? Thinking about your own work, your own research, how does that concept of goal-oriented work or care rehab situate?
Well, you just actually highlighted exactly in my own professional journey how those three things are often still separate. What we do in clinical practice versus what we study versus how we teach. And it's a challenge to really rigorously study goal-directed care because, as Stacie said, it's everybody's journey is their own. And so when we talk about these gold standards around creating research studies, but yet really needing to tailor and be specific to the person we're working with, it does create challenges for creating an evidence base that supports people with where they are. And then also having to take in where that care is being delivered.
So Stacie, you said there were people who were on Team Stacie. So how did you find those people? How did you communicate with them? And how do we learn from that?
Yeah, I think what I learned is that you have to have really a big lofty goal and then little mini goals to reach that lofty goal. The first thing you have to ask anyone that's helping you along your way is, do you support this goal, and do you think I can reach it? And I didn't do that in the beginning, but I learned it along the way, because I think when recovery is driven by the survivor's own values and ambitions, it's far more effective, and the retention rate is far more clear.
Well, I think you're hitting on something really interesting, because in stroke best practice, clinical practice guidelines, one of the recommendations is always that rehab and services should be tailored to the individual and their goals, and it should be built to support transferability post-rehab in day-to-day life. I'm just going to flip to Janet, because I know you've also been involved in guideline development. How do we make that more explicit then?
Well, that's a really great question. The guidelines are driven by evidence that's available and then input from people delivering that care. And one of the things we could do better in creating these guidelines around the world is actually integrating more of the patient voice. And not every country and every guideline development process does that. So, Stacie, as you were saying, what that looked like for you and people that you felt like were identifying with you, when we talk about what great care looks like, sure, we have guidelines around all sorts of things, but what does that mean to the patient? So, we have guidelines for and really strong evidence for organized inpatient care. And it's a really strong evidence base, which means we know that people who have a stroke who are in organized inpatient units and people who receive more rehabilitation generally do better. If we ask patients, though, and stroke survivors what that looks like, they may describe how that could be organized differently and for them. I think similarly, we have guidelines around and really strong evidence for early supported discharge, around multidisciplinary teams, and even the integration of social services and community-based services. That's going to look very different in different places. And so in creating these guidelines, we need to work locally to find out what's there and ask patients to help develop how that would be delivered.
So you made me think of two things. One, Janet and I collaborated with colleagues earlier this year to explore person-centered practice in rehab transitions. And actually what we found was that interventions that were person-centered by virtue of the model didn't explicitly identify how they were person-centered. And so that's published in Stroke if anybody wants to see it. And it then lends itself to serve as an impetus for interventions or initiatives like the World Stroke Organization certification program. So how does it get built in that local contextual piece? WSO is undertaking a global certification initiative, and there may be an opportunity to more further embed what person-centeredness looks like in the context of the certification locale. That's really very interesting.
Yeah, I actually had specialized stroke rehab services. So when you think about how we're working with different countries, I think it's going to be really important to expand the discussion about what's there, who's providing that input, and how to create it. I wasn't so surprised, Michelle, that we didn't find what we went looking for in the literature, because what happens on the ground could look very different.
Absolutely. So that tees up the next big bucket. We promised the audience that we would talk about what good or even great stroke care looks like. So, Stacie, can we start with, if you were to talk about what good or even great, could you just run down a list of things that would be included in good or great stroke care and rehab?
Yeah, from my experience, there were several things that were working well. First of all, the acute care in the hospital was amazing. And I was fortunate to have access to intensive rehabilitation. Even though I didn't go to a rehabilitation center, I was very lucky. The first year, I spent over 1,000 hours in therapies. And today, I still spend around 7 hours a week on my therapies, and it's been 5 years. for me, I do this because I'm still seeing progress, and that for me is great care. But conversely, if my goal was just simply get out of bed, then that having that purpose makes all the difference. Just working on my goals. I mean, that I can work on my goals, and this for me is what great care looks like. In mental health support, because
I was going to ask if you would add anything.
That's especially because of the cognitive and communication issues that some survivors face. I faced it. Mental health support could be better.
As you know, we just talked about, there are all these guidelines available. And the one thing I appreciate especially about the discussion on what great care could look like is thinking about the different levels of care that could be available better and differently. So the World Health Organization put out a really nice framework for rehabilitation in health systems. And, we often talk about the intensity, meaning like how much rehab somebody receives, and how, Stacie, you just referred to how many hours. In that rehab framework, they also have not just community delivered care, but self-directed care. Stacie, for you to talk about still doing seven hours a week, 5 years post, I can't say that I hear that from a lot of people. And often it's because they're not, maybe they haven't been open to the idea that they could continue to recover. Great care could support continued motivation and resources of what you could do 1, 2, 3, 4, 5 years out. That would be great care.
We had an interesting conversation not too long ago with some colleagues around the distinction between rehab and recovery. And is rehab a place, and is recovery an aim? Is rehab a process, and is recovery an ambition? I would be interested in both of your thoughts around rehab versus a place and a space or a process. And Stacie, considering you are still working and investing in yourself in this, what do you think?
Yeah, I like the term holistic care. I don't remember if you said it, Janet, or you said it, Michelle. So I made a bet also with on World Stroke Day. So my handwriting is really not so nice. I used to have really good handwriting, but now after my stroke, I can't write. I can write, but I can't read what I'm writing. But I know that if I work on this every day, that by World Stroke Day 2025, it'll be better. So I believe that if you have a goal and the motivation to achieve that goal, you can do that.
Jenna, I'm going to give you a chance to respond, but Stacie, I just want to follow up because I know with your platform and all of your activities have the ability to connect with and engage with a lot of people impacted by stroke. So when you talk about goal-oriented care, goal-oriented rehab, what's the response of the people that you interact with? Do they have goals? Are they working toward them? What does that look like?
I think that people are looking for someone who will push them a little bit. And that's the part that I play, to make them realize that they can. And if you want it, you can do it.
I really love that. And it, of course, begs the question, Janet, I'm looking at you. How do we then move that approach into care systems, healthcare system design, delivery? How do we systematize the work or the perspectives that Stacie's talking about?
Yeah, I was listening, Stacie, to how you just described that, and I feel as though the integration of people who have had the experience with policy and decision makers is critical. Sometimes people are making decisions, like at the national ministry level, they're making decisions around care or payment or access to things that need to be available in different places across their countries. But they don't necessarily have context for what, in this case, a stroke looks like, what people need, what are those supports. And so really being able to bring experience directly to policy and decision makers, I think, is really important. So they're not making general decisions just because stroke, for some people, is seen as an acute event, meaning we need to address something right up front, the way we do with trauma and traumatic brain injury. This is a chronic condition. People continue to live, continue to return to work. The needs around returning to school, being an active family member, caring for children, like all of those things also need to be elevated into the discussion of, decision-making around resource allocation and how things are paid for. I think that's a really important thing that we could do more of in countries of all resource levels and help people that are making the decisions really understand what this trajectory looks like and what's needed.
Particularly with the most recent data coming out around the economic burden of stroke. But I think being able to situate that, and I this idea of the holistic perspective, what does that look like across a person's lived experience, their life, what it means to them, what matters to them. I think putting that human lens on the economic and social impact, I think, is really important. And it's actually an endeavor for us to undertake in stroke systems. Stacie, we had a conversation once about, engaging people's experiences in a way that underscores some of those data sets and decisions. There's that saying that stories make data sing. And so when you speak to people who are in policy making, decision making, how do you approach that?
For me, I think that this shift that we're talking about requires both a cultural change within the healthcare systems and the commitment to recognizing that person-driven care is essential to effective long-term transformation or recovery. I think there's two things there.
Yeah, and I think we're seeing it systemically. We're seeing a shift in acute to rehab to community to long-term life. Janet, just thinking about some of your global work, are you seeing that in some places sort of maybe more brightly than others?
Yes and no. So, again, there's this balance of research and evidence from research, and then what we feel and believe is a good idea in practice. And I think a great example of that is a concept called task shifting. How do we reallocate what would happen with particular rehab professionals and train other people to do that? So the bright spot of that is we know we can train others in certain tasks to be sure that somebody who's had a stroke feels more supported. But then you have, the balance of what does that mean for reimbursing that person to do that, or being sure that they have the funds to do it, and being sure that it's done safely. Does it actually work? Stacie, you talked about having to go off on your own. Well, do we really need to show that it's better than nothing at all? I mean, clearly you've found that there's benefits from these things. So,
Absolutely.
How do we not find some level of investment in things that we should be developing and testing so people feel supported? That's a really tough discussion with policymakers and people who are trying to reallocate resources.
Oh, it's such an interesting question. It's such an interesting conversation about how do we generate evidence through research that meets the needs of people who are with lived experience, people impacted by stroke, in ways that are contextually dependent and also support policymaking and evidence-informed policymaking. For implementation science individuals, it does actually create an wonderful, amazing opportunity to look at localized interventions that are really effective, and then have the conversation about how do we support. I don't tend to use scale. I talk about proliferating a model so that you see what it looks like in context. And I think that might be a new frontier for local innovation to proliferation. That might be a really interesting opportunity for us to explore.
Oh, 100%. Well, I mean, look at us today. So we're on this discussion from 3 different countries. And so when I think about proliferation, a decade ago, we would never have talked about rehabilitation being delivered through any virtual camera type, direct mode. And now we have, this whole kind of platform of digital health technology, and that even in the lowest resourced regions or countries, they're still leveraging text messages, and nudging people to do their exercises, make sure you're taking your medication, be sure you get up today. And I think, there are a lot of opportunities for us to learn across countries. And digital health technology for me is one of those. People throw it out as, oh, well, not everybody has access. Well, at this point, there is some level of access almost everywhere. It may be spotty. It may not be great. There may be 6 people sharing a phone or a phone number. But there is a pathway there that we can explore, and sharing how to do that. And sometimes across conditions, it may not be in stroke, actually. It may be learning from other places.
And I think by creating a consistent approach to uncovering what truly matters to each individual and to defining clear milestones, healthcare providers can align more closely with survivors' aspirations
and living situations. Right. So what are the goals for you in your context? And then, COVID certainly has unearthed really clearly demonstrated the wealth of opportunities out for virtual. It's now in the Canadian best practice recommendations for stroke. And so that bridging between what matters to people, what are the modalities to support them where they are. And so I think we're coming into an era of really interesting clinical and research interventions that can be used to support policymakers to think differently about stroke care.
Oh, 100%.
Yeah. I've never even met my speech therapist. I still see him 5 times a week, and I've never met him. So
it's all virtual.
Yeah.
Amazing. And it only underscores that we build systems and healthcare pathways and processes that enable people to work with clinicians where and when they are. For the audience, I'm just going to take this moment to flag for you that episode 3 is all going to be about the education and training of all of those that are in the care and support of people post-stroke. And we will talk about upskilling and new modes of learning. So if we were to take the conversation and identify one quick win each, something implementable, what would it be? Stacie, let's start with you. One quick win.
To identify standardized measures to identify survivors' personal goals and to track their progress.
Clear. Thank you. Not easy, but clear and actionable. Awesome. Janet.
I would say a big win would be having governments and healthcare systems integrate digital health technology. So really the range of text messages through platforms like this, whatever they're able. And that way they could stay connected to patients potentially longer in their home and be a resource that would not only support rehab, quick win, digital health technology.
Absolutely. And it really builds on that message that something can be done for anyone everywhere. So to that, I think mine is probably we need to continue our efforts to defragment the stroke pathway of care. So thinking about the holistic experience from acute to community and beyond gives us the ability to bring in all the requisite partners, whether they be in the community or clinical, to support. And it allows us to identify and support people impacted by stroke with new symptoms, emerging issues, challenges arising, and that they really feel like they're being supported holistically, to use your word, Stacie. That would be my quick win. This conversation has been so interesting and so enlightening, and we're out of time for today. So I want to thank you both, Janet and Stacie, for taking the time with us and sharing your insights. I've really appreciated the time, and I hope you've enjoyed it too.
Yeah, thank you, Michelle and Janet. I think this discussion in itself is exactly the model that to engage people with lived experiences. And just we have to keep the conversation going. This platform, all the countries, thank you. It was my pleasure to be here with you guys.
Oh, yeah, for me as well. Thanks so much for inviting us. This discussion on, elevating standards for post-acute care is going to depend on relationships and networks. And here we are, the 3 of us in different countries. And if we can continue the discussion about how do we build networks across countries, across partners, we'll continue to push those standards higher.
Thank you so much, Janet and Stacie, for joining us today and sharing your insights on what optimal care can look like. You identified some opportunities to improve post-stroke care globally and helped us identify some best practices. Thank you all for joining us today. I hope you enjoyed the episode as much as I did. In our third and final episode of this series, we're going to talk about the education and training needs of all of those involved in the care and support of people post-stroke. We'll highlight the importance of continuous upskilling of healthcare professionals, and we'll talk about the training and education requirements of family caregivers and community support workers. And of course, don't forget to subscribe to Neuro Connections. You don't want to miss an episode.